Hi everyone. So after the placenta accreta spectrum, let's briefly touch on placenta previa. So we're going to go through diagnosis and classification and management. We'll also go through risk factor, pathogenesis, and what are the clinical implications of this placenta previa. So definition and classification. Placenta previa is when the placenta is overlying or is close to the internal os, obstructing the blood canal. Traditionally, there's a little bit complex classification, like partial, complete, or like marginal, low lying. Now it's much more simpler. The diagnosis needs to be with TVS, and placenta previa is if it is covering the os in like either fully, partially, either way covering the os. Placenta previa if it is not covering but within 2 centimeter, like touching the os from up to 2 centimeter is low lying, and if it is more than 2 centimeter is normal location. Let's look at the video a little bit. So this is the whole placenta, and you can see the cervix here, so it's covering the os. This is placenta previa. So this is from transabdominal scan. Let's play the video. Again, you can see the placenta is here. This is the uterus, cervix is covering the os. Yeah. Now we've already seen the transvaginal scan one. Placenta is the whole of this, and then is cervix here, so it's covering the os. So epidemiology, it affects 5 in 1,000 deliveries, so 0.5%. Recurrence, if there was previous placenta previa, this recurrent rate is about 4.8%. With more C-section, the incidence is rising. So what are the risk factors? Obviously, prior cesarean section, the more cesarean, the higher risk of placenta previa. You try surgery, any DNC malmatomy increase the risk. Same with accreta, high puberty, advanced maternal age, smoking, twins, increased risk of maternal age, increased placenta previa risk. Because with the twin babies, placenta is bigger, so it's more likely to be low lying. Pathogenesis, implantation location. So normal placenta usually implant in the upper uterine segment is where the blood flow is, blood supply is the best. So the theory is that in the previous, like a multiple pregnancy or a MATIP or scar, then if the previous fundus has been scarred so many times by previous pregnancy, the placenta try to look for a new place to implant, and then they implant a little bit lower, and then it increase the risk of placenta previa. So that's why endometrial damage or scarring in upper uterus with previous surgeries or previous deliveries, pregnancy, it increased the risk. When we say placenta migration, is most low-lying placenta resolved by third trimester. Only 3% of placenta apparently which was like low-lying in second trimester remains at previa or low-lying. So they migrate to better perfused area as the lower segments stretch in the third trimester. But if there are scar or some surgery, then this impair the process and result in persistent placenta previa. Association with placenta accreta spectrum, we have gone into details on the placenta accreta spectrum PowerPoint. Is PAS incidence is 1.7 in 10,000 baseline risk in general population. But if previous C-section and placenta previa, the risk jumped to 5% risk.
So factors affecting migration potential. So if the placenta is just low-lying, not covering the os, is more likely to migrate and become like not low-lying placenta. But if it is covering the os, is the overlap distance. If it is overlapping more than 2 centimeter on the os, is unlikely to resolve. If it is within 2 centimeter, that means like the overlapping area is not like a lot, only 1 or 2 centimeter overlapping the cervical os, internal os, 88.5% chance of resolution. And also the factors that will make it less likely to migrate up, like thick placenta edge, or one with diagnosis is already advanced gestation and still not moving, or prior cesarean section. In these cases, then is more likely to persist as low-lying or placenta previa. Impact of previous cesarean section, obviously reduce migration potential and scarring, so there's like placenta cannot move effectively. Additional risk is placenta can attach more firmly, and because of the disruption of the endometrial layer, and then it can attach into the myometrium and increased risk of placenta accreta spectrum. And obviously higher chance of antepartum hemorrhage and postpartum hemorrhage. Clinical presentation. So placenta previa usually present with painless vaginal bleeding, especially in second or third trimester. It could be some triggering things like vaginal examination, speculum, or sexual intercourse, or because she was going into labor that the bleeding started, or it could be spontaneous bleeding. So diagnostic timeline is first 20 weeks. We always check the placenta attachment and localization. If it is low-lying, follow up at 32 weeks, and if it is still low-lying or previa, rapid scan at 36 weeks, and if it is still low-lying at that point, we arrange for delivery like C-section. Differential. So any woman come in with bleeding during pregnancy, if it is painful, there's very tender uterus, also abnormal CTG, is risk of placenta abruption. Sometimes it's not placenta previa, placenta is high up, it's no pain. It could be just local causes, cervical atropine, quite common in pregnancy, polyp, or some vaginal infection like severe candidiasis or trauma. With the previa is bleeding is usually painless, but the diagnosis is not with examination. It has to be confirmed with scan. Of like we would have already known from previous scan if it is previa or not, and we have to check well-being of fetus and mom and hemodynamically stable or not. So risks with the placenta previa with mom, placenta is low-lying, so it can bleed before delivery, 10-fold increased risk of APH compared with normal placenta attachment. Blood transfusion risk, 5-fold increased risk. They can go into preterm birth, hysterectomy, ICU admission, and even death. For neonate, increased perinatal mortality, about 3 to 4-fold increased risk. And also they can go into preterm birth, so prematurity risk. And low APGAR scores and NICU admission risk. So management principle, antenatally, expected management if no bleeding, hospitalization if any bleeding, or live far away from hospital. Delivery plan is if it is within 1 centimeter, within 2 centimeter, usually cesarean section. More than 2 centimeter, we can try vaginal delivery. Within 1 to 2, some allow for vaginal delivery case by case. Delivery setting is if it is uncomplicated, no bleeding, just placenta previa cases, elective C-section around 36 to 38 week. And if prior cesarean section and our abnormally invasive placenta or placenta accreta spectrum is suspected, delivery in tertiary center, and senior obstetrician and anesthetist are always present because there's risks of bleeding, and blood products should be available with HTU ICU care facility available. Just a short presentation for placenta previa. Thank you guys.